Good morning, teacher. My name is Gustavo Bocca, and I will talk about the long-term outcomes of partial oral treatment of endocarditis. So, we have the definition. According to my clinic, the endocarditis is a life-threatening inflammation of the inner lining of your heart chambers and bulbs. That is the endocardium. So, endocarditis is usually caused by infections like bacteria, fungi, or other germs from another part of your body, such as your mouth, for example, that spread through your bloodstream and attach to the damaged areas in your heart. So we have more definitions for endocarditis. The endocarditis may develop slowly or suddenly, depending on what germs are causing the infections and whether you have any underlying heart problem. Successful treatment requires appropriate antibiotic therapy. Initial NP therapy may include a vancomycin or ampicillin sulfactant, plus an aminoglycoside such as rifampicin. The choice of defined antibiotic therapy is based on a cause microorganisms. So we have a video to understand what is endocarditis.
This is Dr. Cal Shipley with a review of endocarditis, cardiac valve vegetations, and stroke. Endocarditis can occur when there is fungal or, more commonly, bacterial infection in the bloodstream, a condition known as septicemia or sepsis. As the organisms travel through the heart, they attach themselves to the valve leaflets between the heart chambers. The oxygen and nutrient-rich environment found in the left side of the heart results in rapid growth of organisms, which form clumps known as vegetations. Unpredictably, the vegetations may detach from the valve leaflets. The vegetations are then ejected into the aorta, where they may travel up into the arteries of the brain, causing obstruction to blood flow and subsequent stroke.
Now we have the applications in medicine. Okay, so patients who receive oral treatment have less comorbidities than intravenous treatment. That is to improve the agility of the medical systems, which today is over its limits with cases of SARS-CoV, allowing patients to have controlled outpatient treatment and reduce their exposure. So the outpatient follow-up of patients with effective endocarditis and oral antibiotic therapy reduce the physical, psychological, and economic burden of the doctors, the patients, and their families. Okay, now we have another video.
Patients with infective endocarditis on the left side of the heart are typically treated with intravenous antibiotic agents for up to 6 weeks. During the initial phase of hospitalization and treatment, patients often require intensive care and close monitoring. After this period, many patients remain hospitalized to complete intravenous antibiotic treatment. In this randomized non-inferiority trial, 400 adults in stable condition who had endocarditis on the left side of the heart caused by Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or coagulase-negative staphylococci, and who were being treated with intravenous antibiotics were randomized to continue intravenous treatment or to switch to oral antibiotic treatment. In all patients, antibiotic treatment was administered intravenously for at least 10 days. The primary outcome was a composite of all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia with the primary pathogen, from the time of randomization until 6 months after antibiotic treatment was completed. In the intravenously treated group, the primary outcome occurred in 24 patients, as compared with 18 patients in the orally treated group, with a between-group difference of 3.1 percentage points that met non-inferiority criteria. This trial showed that in medically stable patients who had endocarditis on the left side of the heart, caused by Streptococcus, E. faecalis, S. aureus, or coagulase-negative staphylococci, a transition from intravenously administered to orally administered antibiotics was non-inferior to continued intravenous antibiotic therapy. Full trial results are available at nejm.org.
We can talk about of the pros and cons in this topic. Pros is that it reduced the hospital load, allowing to attend patients with more chronic symptoms, like now in the pandemic situation. It is safe and feasible to complete the treatment of highly complex endocarditis with oral treatments. Okay? But the cons are that the patients treated with oral antibiotic therapy underwent surgery more frequently and require more hospital admissions. 1 year mortality is similar to that of patients that are treated by an intravenous therapy. Another contrast are that the 1 year mortality is similar to that patient that is treated by intravenous. But in the case that in patients that are in a stabilization condition who had infective endocarditis on the left side of the heart, a change from an intravenous antibiotic treatment to a early oral antibiotic treatment is not associated with a delayed treatment failure, like in the last video. So we have the last video of endocarditis.
The pathogenesis of infective endocarditis begins with damaged heart valves from congenital heart disease, rheumatic fever, IV drug abuse, and the placement of intracardiac devices such as implantable defibrillators and pacemakers. Valve damage leads to sterile deposits of platelets, red blood cells, white blood cells, and fibrin called non-bacterial thrombotic endocarditis, or NBTE. If a sufficiently virulent organism is present in the bloodstream in sufficient amounts, it may colonize the damaged valve and its associated NBTE, and now the mass of bacteria and the NBTE becomes infective endocarditis. 80% of infective endocarditis is caused by gram-positive cocci, of which Staphylococcus aureus is the most common. The HASEC group of organisms consists of fastidious gram-negative bacteria that are an unusual cause of infective endocarditis. They are, together with fungal infections, notoriously associated with large, friable vegetations, which can easily break off and cause emboli to vital organs. Enterococcus causes about 10% of infective endocarditis. Enterococcus is a notorious problem if it causes endocarditis because agents that interfere with the organism's cell wall can inhibit these organisms, but cannot kill them. However, bactericidal therapy is essential to prevent recurrence of endocarditis of any cause. Thus, for enterococcal endocarditis, potentially toxic aminoglycosides must be added to cell wall agents for the entire period of treatment to eradicate the infection. Diagnosis is confirmed by multiple positive blood cultures and visible vegetations noted on echocardiography. Definitive management of patients with infective endocarditis is best accomplished by an infectious disease specialist, and the nuances of antimicrobial therapy are beyond the scope of this lesson. However, while awaiting culture results, empirical therapy of native valve infective endocarditis with vancomycin plus ceftriaxone is recommended. For prosthetic valve endocarditis, the combination of vancomycin plus gentamicin plus oral rifampin is recommended because of the possibility of methicillin-resistant Staphylococcus aureus, or MRSA. This combination is also recommended for methicillin-resistant Staphylococcus epidermidis, MRSE. Adjustment of antibiotics can be made by an infectious disease specialist when available. In some cases of endocarditis, valve replacement early in the course of endocarditis should be considered because it is associated with a lower mortality than elective.
Now we talk about of the issue applications in Ecuador. Oral antibiotic therapy against bacterial endocarditis in Ecuador has a recent registration in a degree thesis in which the disease of several patients was treated at the General Hospital of Puyo, where post-operative stays were treated with oral antibiotic therapy. In this case, the patients have blood cultures and antibiogram to see the causative agent of the pathology. The results of that were that the patients were discharged without symptoms of heart failure or dysfunctionary aortic valve in a period of many months. So they don't have any disease with the oral medication. In this case, that is the antibiotic oral therapy. That is the importance of this topic. Now, we have the conclusion. The long-term oral antibiotic therapy or treatment give us certain advantages in terms of the burden that a medical center can receive, since its outpatient management will allow us to have greater fluidity in patient care. But at the same time, its disadvantages is that does not allow for a quick result as in an intravenous treatment, and it is necessary to have a very regular checkup to see that the patient doesn't not develop comorbidities. Okay, thank you.